The following podcast is part of a certified educational activity titled Seek and You Will Find in Advanced GI Cancers, Identifying and Targeting Uncommon but Actionable Genomic Alterations in Colorectal, Pancreatic, and Other Cancers. Access the entire activity and complete the post-test at peerview.com/PCK860. Downloadable slides and practice aids are also available.
Thank you. Good evening, all. It fills my heart with joy unspeakable to see you all in person here. Again, it's a trip to ASCO GI after 4 years, right? 4 years? 2 years or 4 years? It seems like 100 years ago, with the pandemic on. Yeah. And, thank you for being here. Seek and you will find in advanced GI cancers, identifying and targeting uncommon but actionable genomic alterations in colorectal, pancreatic, and other cancers. Again, we'd like this to be a panel discussion and an interactive discussion. Although the stage is set like a presidential debate, we are not going to debate here. We are all going to, we are all in one team against cancer. So let me go ahead and introduce myself. My name is Vivek Subbiah from the University of Texas MD Anderson Cancer Center. I'm a medical oncologist. I work as an early phase drug development medical oncologist and the Center Medical Director for the Clinical Center for Targeted Therapy at MD Anderson Cancer Center. It is my pleasure and honor to introduce Dr. Beg, Dr. Parikh, and Dr. Rashid here. So let me go ahead and introduce Dr. Shalan Beg so that he can introduce himself. Dr. Beg.
Great. Thank you very much. I'm a medical oncologist. I focus on early phase drug development and GI cancers, and I'm the Vice President for Oncology at Science 37. I hold an adjunct faculty appointment at UT Southwestern where I see patients as well. It's a pleasure to be here, and thanks for joining us.
And over to Dr. Aparna Parikh.
Hi, I'm Aparna Parikh. I'm a GI oncologist at the Mass General Cancer Center. Also specialize in colorectal cancer and do both early stage and late stage development in GI cancers.
Dr. Rashid, I had the pleasure of bumping into him in the flight when it landed. Although we work at MD Anderson, we haven't met each other before. That's how big MD Anderson is. So it's
otherwise pleasure. We work very closely. I am a GI pathologist who also sign out molecular diagnostic. So it's part GI histology and part molecular diagnostics.
So it's a pleasure and honor to welcome Dr. Beg, Dr. Parikh, and Dr. Rashid for this evening. I think we're going to have a well-rounded panel discussion. And we have medical oncology expertise, GI oncology expertise, clinical trial expertise, and then deep pathology expertise here. Again, what are the objectives of this program? Right? To understand the current guidelines and evidence related to molecular testing and targeted therapeutics, enabling timely diagnostic and treatment of gene fusion-driven GI cancers. To be able to implement collaborative, multidisciplinary genomic testing protocols designed to capture less common but actionable molecular alterations in metastatic or locally advanced gastrointestinal cancers. To be able to construct safe, individualized treatment plans for patients with advanced GI cancers who present with uncommon genomic alterations. So, brief agenda for today. We had a welcome introduction, and I'll be talking about the recognition of gaps and opportunities for improvement, why we are here. And there are a lot of people virtually signed up for this, watching from their homes. I think one of the silver linings of the pandemic is the way we operate, right? I think more than being in person, it's great to see you all in person, and it's great to see you all face to face. But of course, learning educational activities can be done remotely, and many people have joined remotely. So we will have an audience Q&A from people joining in remotely as well. And clinical consults, we'll learn about key molecular testing strategies and targeted treatment of GI tumors driven by less common genetic alterations, like picking needles in haystacks. The first part of the session is going to be test before you treat. Real-world systems for identifying fusion-driven cancers for tailored therapy. And why do these needles in haystacks, picking less common genetic alterations matter? And also, we're going to explore strategies for delivering personalized treatment plans. So why are we discussing this topic? Right? So let's talk about we need to recognize gaps and opportunities for improvement. Again, 20 years ago, 30 years ago, they said we cannot sequence a human genome. It took 2 decades ago, it took billions of dollars to sequence a human genome. Right now, we can get genetic testing done in major academic centers and in commercial available companies all across the US and the world, for $5,000. There are many, many companies in Asia, in India and China, that say that they can get the cost down to less than $100. So again, genomics, again, my personal belief is that genomics at one point should be part of diagnosis so that we can offer customized therapies to our patients. So advances in biomarker testing and targeted treatment have improved the outcomes of many patients with cancer, and biomarker testing has become standard of care for many tumor types. However, recent analysis of real-world data have revealed suboptimal rates of biomarker testing and limited access to testing for some patients. Even when biomarker testing is performed, use of inappropriate testing methods has been reported. So this hinders the identification of key molecular alterations, including that are less common but still highly relevant, like gene fusions of NTRK and RET. A hotspot mutation is done, and NTRK or RET is not tested in the hotspot mutation panel. But the clinical medical records would probably indicate that mutation panel is negative. It's not. So the appropriate biomarker testing have to be performed. This leads to suboptimal treatment selection, suboptimal treatment timing, and delivery. This has been found to be problematic in many settings, including community settings and many academic settings as well. So why do we need to test? Our patients with cancer miss out on opportunities to benefit from specific biomarker matched therapies. Example, RET inhibitors and TRK inhibitors. And these patients tend to have a poorer outcome when we don't treat them with the appropriate therapy. A lot of improvement is needed. The best practices for biomarker testing has been established. Several targeted therapies for gene fusions have been approved by regulatory authorities in the US and globally, and others are in development. We have a long way to go. There are so much opportunities here for improvement. So let's talk about GI cancers. When we think about GI cancers, the first tissue-agnostic approval was a major event, 2017. 2017, immunotherapy was approved for MSI-high-positive cancers. It was a marriage of immunotherapy and genomics. That opened up the world of tissue-agnostic precision medicine. Following that, NTRK inhibitor, Laratracin, was FDA approved for NTRK fusion-positive cancers across multiple tumor types, including GI tumor types. Following that, a year later, another NTRK inhibitor, entrectinib, was also approved for NTRK fusion-positive cancers. Following that, TMB high, tumor mutation burden greater than 10, also received an FDA approval for immunotherapy. Again, this case was pembrolizumab. A second PD-1 inhibitor, dostarlimab, was approved for DD MMR high positive cancers. The two recent tissue-agnostic approvals was BRAF V600E and RET fusions. Again, let's talk about more in detail about RET fusions and later about NTRK fusions, because the latest kid on the block in fusions is RET fusion that is approved in a tissue-agnostic manner. What are the emerging biomarkers in GI cancers? Of course, we have NRG1 fusions, we have HER2 new amplifications, and FGFR2 fusions in cholangiocancer, and many other cancers. So let's talk about the timeline of discovery of fusions. This is important. Small marker chromosome was observed in patients with CML as early as 1960. CML was the poster child for fusion and poster child for precision oncology. And following that, fusions were discovered in salivary gland adenocarcinoma. The 1122 translocation, the EWS FLE1 fusion, was discovered in Ewing sarcoma, which is a sarcoma that strikes adolescent and young adult in the prime of their lives. RET fusions were identified as one of the first oncogenic kinases to be cloned and identified using lymphoma DNA. BRAF fusions were identified in the 1990s. Between 1980 and 1990, NTRK fusions and ROS fusions were discovered. 2000s, we saw PDGFR fusions. We started discovering more and more fusions. After discovery of ALK fusion and ALK-targeted therapy, and RET fusion, mark the date, RET fusion was identified in non-small cell lung cancer in 2012. 5 years, not one, but 2 selective RET inhibitors entered first-in-human clinical trials in 2017. I remember dosing the first patient with a RET inhibitor. Approximately 3 years later, the first selective RET inhibitor, selpercatinib, in May 2020, in the peak of the pandemic, was FDA approved. The timeline of approval in a rare biomarker-driven disease within 3 years was unprecedented. So again, we are seeing that if we identify these patients, patients can benefit from these targeted therapies. Let's talk about that in the next set of slides. So what is a gene fusion? You all know about gene fusions. I don't want to talk more, but gene fusion is a hybrid of 2 genes that results in downstream activation of in the MAP kinase pathway, the PI3K pathways, leading to carcinogenesis and oncogenesis. So what do we have? Like again, after ALK fusion seen in lung cancer, ALK was seen in multiple other cancers as well. If we take the TCGA data, other than ALK, we see BRAF fusions, FGFR2 fusions, RET fusion, not only in lung cancer or thyroid cancer, but across multiple cancer types. So we see a long tail of kinase fusions across cancer. So ultimately, these biomarker-driven cancers may form a separate subgroup of tumors treated in a similar manner, like an alcoma, a retoma. Again, that's my personal belief. It's like a decade later, we will be thinking about a retoma. We'll be thinking about an alcoma. And when we move away from chemotherapies, we are not there yet, but we'll get there at some point. Tests before you treat. That's why we need to test before we treat. Real-world systems for identifying fusion-driven cancers for tailored therapy.
So we'll start with the case here. And again, I'm a colorectal cancer specialist. So this is a case that is very typical in my clinic. So this is a 59-year-old woman with advanced CRC, and her presentation was as such. So she presented with a couple of months of abdominal discomfort, bloating, and weight loss. All typical symptoms we see in GI cancers. Was found to be anemic with a hemoglobin of 8, an elevated CEA, which we don't see in all colorectal cancers, but many. And her workup found mass in the ascending colon, and in colon cancer, sidedness is important to describe. So knowing if it's in the ascending colon or descending colon matters. Has both prognostic and predictive significance, and the biopsy was shown to have poorly differentiated adenocarcinoma, and unfortunately a CT scan had widespread lesions across the liver. So this is a de novo MET CRC, no prior history, no prior treatment history, and has showed up in your clinic with a de novo diagnosis. So how do you approach molecular profiling to capture the diagnosis and capture the relevant biomarkers? And look forward to hearing Dr. Rashid talking about the different techniques to capture relevant genomic alterations.
Okay, so I think this has been introduced. What we're going to talk about are these RET and TRK fusions. And what's happening is that there is a chromosomal translocation where part of a chromosome joins another gene. And what we have to understand is that this is very simple way of thinking about this event. Of course, there is a translocation here. There may be another translocation on the other chromosome also. And sometimes there is loss of gene also. So it could be, it is complicated. Every patient will have a different event. So we are going to go over some of these scenarios. And so what happens is that the two genes that we're going to talk about today, a 3' end of the gene has kinase from one gene, which joins 5' end from another gene, and it forms a fusion gene which is not physiological. And this gene is expressed. The gene which is joined at the 5', this is highly expressed in the tissue where this happens, with the result that there is RNA which is hybrid. It has 5' from one gene and kinase from the 3' gene. And this is expressed also. It's a hybrid protein which is not normally present in the cells. There are various different methods to detect that. Some are based on DNA, some are based on RNA. The RNA-based methods are best because we're going to go over that. Because they are more sensitive, and you can find the fusion partner easily with this. DNA-based assays are used often also. The advantage of that is that RNA is very difficult to extract from formalin-fixed tissue that we use routinely, and DNA is much better than that. But again, the amount of sequencing that you have to do is different for DNA-based methodology in contrast to RNA-based methodology. So these are 4 or 5 different methods that are used often. NGS-based assays, again, they are fairly expensive as compared to other methods. The advantage is that you get a comprehensive profile. You get the mutations, you get the other genetic events, and you get the fusion. So you can decide which is the best therapy for the patient. So of course, the cost is consideration because these are expensive as compared to other methods. So NGS will give you genetic mutations, including insertions and deletion, chromosomal changes, also rearrangement, and copy number changes, and also fusion. So this is a cartoon of red gene. This particular gene is on chromosome 10, and it has multiple exons. You can see, and this is just a depiction, but some of the exons are separated by a large intron. So these lines denote that this protein has an extracellular domain which binds the ligand. It has a cysteine-rich area which has a lot of cysteine residues, and then it has this yellow-colored domain, which is the kinase domain. Here at the bottom, this gene is altered in patients who have MEN2A and 2B syndrome and familial medullary thyroid cancer. And these mutations are predominantly in the kinase domain and in the cysteine-rich area. So on the right-hand side, it shows some of the cancers which are associated with the fusion. Thyroid cancer, as has been pointed out, it is present in 10 to 20%. Lung is 1 to 2%. The other cancers, including Spitz nevi and colon cancer and pancreatic cancer, it would be less than 1%. So it's not a very common event in other tumors apart from the one that includes thyroid and lung. The translocations, the fusions occur in exon 11, 10, and 7. So it has multiple areas which are targeted with that thing. And what's going to happen is that it will have either the kinase domain, it may or may not have the transmembrane domain, so it can be, it may be intracellular protein. It's not displayed on the membrane. So this again is data from lung that these are the four most common partner with RET. So you can see that these it doesn't matter what these genes are, because the reason it is picking these genes are because these are expressed in lung, for instance. And this is the most common, and it can have 7 different variants, 7 different areas which are targeted. So we have to design assays which are going to capture all the fusions that we can that we see or we can think of for each of these fusion proteins. The other method which is used is a FISH assay. There are 2 types of probes. One are called, these are fusion probes. They are 2 different colored probes which are close together. So if there is a fusion and these 2 parts separate, so they are not together. If they are together, they give like they will give a blue color, but if they are separate, then we see red and green, which are separated from each other, so we know that there's a fusion event. The other one is a break apart probe. Again, when there is a fusion event, the one probe is the light is quenched by the other, and that separates and the light changes. So these are the 2 common type of probes that we use for FISH assay. So again, we are going to say that a few times, that the problem with DNA-based assay for fusion is that these exons are separated by large introns. And these events are mostly in the introns. So we have to sequence a lot of gene to find the area of fusion. Or we have to come up with a different strategy to find where the fusion is and what is the fusion partner. So this is from a study. This is, I think, ROS gene, which was studied by several different methods. These were 20 tumors, and they found that there were some tumors, they were not able to find the area of fusion. So again, this is a genomic viewer. You're going to see more of that. These are the exons. This is 31. This is exon 32. There's a large intron here. And these mountains here, this shows how much sequence at that particular nucleotide we have. You can see that there's a good amount of sequence here, and there's some sequence here and here. But this area, there's no sequence whatsoever. And the reason is that this has 2 line elements. Now, line and LU elements, these are repetitive sequences which make about 40% of our genome, and they are very difficult to sequence. And so because of that, the most likely explanation that they were not able to find the area of fusion was because they were in here somewhere, and they couldn't sequence using the DNA sequencing that they were using for this particular study. The same point here, that you have exons separated with a large intron in this NTRK3 gene. So you have to come up with a different strategy to find a fusion in this. This shows a comparison between DNA and RNA. So if you think that there is a fusion here, this is one exon, this is another exon, and the fusion would be somewhere here. So we'll have to sequence the entire area to find the area of fusion. With RNA-based technique, we will use RT-PCR, and with the result that the fusion protein, the cDNA for the fusion would be fairly small. It will be easier to sequence. And I'm going to show you some examples of that. So again, this is a comparison between DNA and RNA. I don't have any stocks in RNA technology, but so large intron is a problem. Repetitive elements in introns are a problem. Low tumor sample number. Again, we are trying to find, we use DNA from tumor that have 20% cellularity, and one of the chromosome will be altered. So we are trying to find something like 5% of the DNA would have that, would have the event that we are looking for. But RNA, these genes, the fusion genes are overexpressed. They have, if the other genes are like in sort of a low thousand, they would be in 10,000 and 100,000. So you have much more of this fusion cDNA which is produced. So they should be easy, like they are easier to find because of that also. And again, it's a problem because the event, we think it's very simple that there are two chromosomes which break and they join. But the event can be very complex, and with the result that it may show different results with fish and with immunohistochemistry and DNA or RNA-based techniques. So you have to use sometimes multiple techniques to come up with the right answer. So again, the sensitivity and specificity varies by different technologies, different labs. The NGS is expensive, but it provides a comprehensive tumor profile. In our institution, we had figured out that if they ask for 2 or 3 genes, that would be the same as doing an NGS. So if they ask us to do 2 or 3 genes, we say that we will do NGS instead of giving you individual genes. So you will get a comprehensive view. RNA-based methods are more sensitive. I showed you. It shows you the fusion partner easily, but there is a higher rate of failure to extract RNA.
All right, great. Thank you so much. Thank you. Wow, wow, wow. Glad we have amazing pathologists to do all the behind-the-scenes tough work. Thank you so much for sharing with us. So again, this what happens in the back end when we see these RET and NTRK fusions in the clinic, and we get this excitement. So in the next slides, we're going to showcase why we need to painstakingly pick these needles in haystacks and test all this. So less common genomic alterations matter. Strategies for delivering personalized treatment plan. That's going to be the next agenda. So going back to Margaret's case, please, go ahead.
Yes, so Margaret comes into the clinic, and again, in awe of all the work that our molecular path does on the background. So you do broad-based testing for this patient. Again, remember, she was de novo metastatic disease, and she it was started on systemic therapy. But taking a step back to the questions from the earlier slide, I hope Dr. Rashid's talk really drove home the point that comprehensive genomic testing is standard of care for these patients, and we do that at the outset. And when you're looking at the different tests, it is important to understand if it's a DNA-based or an RNA-based test. And as we are learning more and more about these fusions and have therapies, extremely effective therapies for these fusions, having an RNA-based test is critical and is something that you should be looking for and asking for. We have other technologies such as ctDNA, which are getting better for fusions, but not quite as sensitive yet as the tissue-based testing. So when a patient with colorectal cancer walks into the clinic, you're doing broad-scale testing, and that's just not for these fusions. We have other important biomarkers that will immediately dictate treatment. So, colorectal cancer is becoming sort of subsets of subsets. So we have MSI high, which there's a first-line indication for, and then, beyond first line, HER2, BRAF V600E, other BRAF alterations, KRAS, which is no longer just KRAS. G12C has made it into colorectal cancer as well, and so really important to do comprehensive testing. And then, of course, the fusions as well. So she gets started on systemic therapy with doublet and bevacizumab, which is pretty standard with colorectal cancer. We either give doublet or triplet therapy with the biologic, and the biologic is based on sidedness and RAS status. She ultimately goes on maintenance therapy and is followed with surveillance on maintenance. And at that time, she starts to have some progression in her livers. And meanwhile, importantly, NGS used during her baseline assessment captured the RET fusion. So now we have to think about, you have a patient that's progressed on chemotherapy. We could go back to that chemotherapy that she was on, but what's the next best step for her? And what's the best next treatment? And we have now, and we'll go over some of the data of some of the new RET inhibitors, but maybe, Shalon, passing it to you to sort of think about how would you think about this patient's next line of therapy as well?
Yeah, I think it's a great option for this patient who has standard systemic chemotherapy treatment options to go back towards. I'm not seeing any mention of KRAS mutations. There are options around EGFR inhibitors that can be used. There are irinotecan-based chemo treatments that can be used. But really, I think this patient's struck oil or gold, however you want to look at it, with a RET gene fusion. And I think with a lot of the development that's happening in the space with RET-specific treatments and with a pipeline of approved drugs and drugs in the works, it's definitely worth a discussion and to see if they want to move to more targeted therapy based on their genomic profile.
And previously, prior to these more selective inhibitors, we had a toolkit of, standard multi-kinase inhibitors, which were quite dirty inhibitors, but now we have options, and, one particularly that we'll talk about that has an AllSolid tumor indication for RET.
So recent developments and new directions for RET inhibitor therapy in GI cancers.
So, as we've talked about today, fusions are truly a needle in a haystack in GI cancers. So predominantly these fusions are seen in non-small cell lung cancer and thyroid cancer. But when you, find them in other GI cancers, and you can see across the board, less than 1%, less than 1%. But for that one patient that's less than 1%, that's 100% for that patient, and it is truly kind of hitting a gold mine there. There are different fusion partners across cancer types, and we'll show you some data, some of the fusion partners. But again, increasingly rare, and we all in our careers will have a couple of these that come up in clinic, but incredibly important to look for given the exquisite sensitivity of fusions to these selective agents. So on the top here, you can sort of see the first generation of the more kind of dirty multi-kinase tyrosine kinase inhibitors that included, RET, but were not by any means selective, and that included drugs such as lenvatinib and cabozantinib and alectinib. And then we started having the selective TKIs being developed with selpercatinib and pralsetinib. And, selpercatinib is the drug that you would use, here. That's where your label is for all tumor agnostic or a tumor agnostic label. So indication independent. And we've just highlighted here the indication there. So very good option for this patient. And some of the, I think Vivek may talk about this a little bit later, but some of the side effects and things that you're watching for with selpercatinib, you get a little bit of hypertension, some LFT, some dry mouths. But here was the study that really kind of changed the landscape for this. So this was a standard phase 1 with the phase 2 dose expansion with, again, all oral dosing, BID dosing, 160 milligrams BID. They had the common phenotype cohorts with non-small cell lung cancer and thyroid cancer, and then 45 patients in other cancer types. And then they had a tumor agnostic efficacy population as well. And the primary endpoint was ORR. And here you can again see across tumor types responses here. And again, just highlighting some of the GI cancers in pancreatic cancer in blue, colon cancer in red. Again, highlighting great responses across tumor types. When we looked at it, so the overall response rate again was 44%, and when we looked at it, again, small numbers, but across other tumor types and GI indications, here on the right, so again, patients, sample sizes smaller, 11 for pancreatic and 10, but remarkable response rate. So 55% response rate in pancreatic cancer, 20% in colorectal cancer. And to give you a benchmark of refractory colorectal cancer treatments, response rates at single digits. And some of these patients, again, that I showed you on the previous slide, beat that 20%. When you look at the AEs, well-tolerated drug, and as you can see here, ALT, AST, some LFTs, the dry mouth, and the hypertension were the notable AEs, but all very manageable. So no kind of DLTs emerged that were really limiting for patients. So well-tolerated, well-tolerated drug, and in this trial, only one patient ended up discontinuing drug to a treatment-related AE. And I actually don't know which AE that was that patient discontinued. I'm not sure if you remember, Vivek, but again, a very well-tolerated drug.
Yeah, the drug is extremely well tolerated. Yeah, again, RET is a tissue-agnostic target, and this was also validated by a second selective RET inhibitor, pralsetinib, and this was showed also activity across many GI cancers as well. And as Aparna previously shared, pancreatic cancer is one of the toughest cancer to treat, and 55% response rates in pancreatic cancer, that's been phenomenal. Again, Dr. Beg and I personally treated patients with RET fusion positive pancreatic cancer. Again, picking these needles in haystacks in young patients with pancreatic cancer, and seeing how they benefit from treatment. Again, that's what makes an oncologist go to clinic and go to motivated to go to clinic to see these patients respond, see these patients do well. That's why Dr. Rashid and colleagues in pathology work hard to get and identify these fusions here.
And maybe, Vivek, just highlighting again the response from your data, right? That was the second study was independent of non-small cell lung cancer, independent of thyroid, and still had a 57% response rate. So truly remarkable across tumor types. So I think going back to this patient.
Yeah, so I think one of the points, Vivek, I've heard you make a lot is that genomic profiling is part of an adequate diagnosis. And we think about genomic profiling as strategies that we use to decide what kind of treatments we're going to go, and that's certainly a fact, but really the adequate characterization of the tumor upon diagnosis, genomic sequencing needs to be part of that in this day and age with the development of medications like what we're talking about right now. And thankfully, you gave the example of the patient who we're talking about. We're now asking ourselves questions like, how long do we continue treating someone who has a complete clinical response to these treatments? When they progress, what do we do in adding additional treatments? Do we continue the suppression of the oncogenic driver and add other medications? And in terms of the side effects, what are the long-term consequences that we need to worry about? So Aparna and Vivek, how do you approach these scenarios for this group of patients who, once we find the needle in the haystack, are having deep and clinically meaningful responses, and we want to ensure that we see long-time sustainability for their diseases?
Yeah, I mean, so I think unlike, immunotherapy, where I think it's a little bit unclear what to do after patients, go into a CR or have disease control sort of a couple years into treatment, and the duration is a little bit more controversial, I think, with these targeted therapies. I think you continue till the time of, progression. And I think the MSI piece here is really important. It is known that these fusions are enriched for MSI high status. So, about 30% of patients that have a fusion will also be found to have MSI high status. And so we don't really know yet in terms of sequencing. Should we give the immunotherapy first? Should we do the targeted therapy first and then move on to the immunotherapy? And data that we may just have to sort of generate as we prospectively collect information on these patients, because a trial is going to be hard to do, looking at that sequencing question for such a rare subtype, and then even a rare subgroup that are MSI high. But these are clinical decisions that we have to kind of face with, and the AEs we talked about. But Vivek, I don't know if you have any other comments on duration or timing of immunotherapy.
Yeah, again, the patients with CRC, the duration, if they do respond, they do respond for a long time. And in the clinical trial, the duration of treatment with colorectal cancer was 9 months. And interestingly, again, what we saw was if you see the response rates in pancreatic cancer, 55% response rates in pancreatic cancer, whereas in colorectal cancer, which was 20%. Right? When we see this difference, we had to take a step back and think about what are the standard of care options in colorectal cancer, and what is the response rates in colorectal cancer with the standard of care options. Regorafenib, we went back and looked into the response rate. It was 1%. And with tipiracil, Lonsurf, the response rate was 1.6%. So compare that with this treatment. And we personally taken care of patients who had stable disease with RET fusions on RET inhibitors with colorectal cancer, clinically benefiting from treatment. So again, RECIST-based responses may not be the best way to assess responses in colorectal cancer. Probably we need to think about PFS and other measures of success in patients with colorectal cancer. What do you think about that, Dr. Baig?
Absolutely, especially in situations where we have other additional lines of therapy, your overall survival results may also be muffled. So the world where we would get clear signals on subsequent and sequential randomized clinical trials in an era such as what we're facing in colorectal cancer with various molecularly targeted options for these patients, the endpoints are tricky. And I think response rates for early signal of activity is helpful for a lot of these treatments. Progression-free survival, especially for drugs that have a favorable side effect profile, I should say favorable, but I should say one which can allow patients to continue living with high quality of life, is very meaningful. And I think we are in a world where we are questioning what the endpoints need to be for this group of patients.
Yeah, and I think, the other interesting thing, just looking at the differential, effects across tumor types, I think we've learned from these other targeted therapies, not necessarily fusions, that, tumor context does, matter some. BRAF was the poster child of that, where you saw remarkable response rates in melanoma, and then you took it to single agent BRAF therapies in colorectal cancer and had single digit response rates, because we learned quickly that you had, reactivation of kind of MAP kinase pathway. We see that with G12C. It's exciting in colon cancer. It's not as good as it is in lung cancer. So I think we'll learn more as we start to treat more of these patients. But as Dr. Spy was mentioning, the response rates are still impressive in this patient population.
And great problem to have, right? For us to have to ask these questions for this group of patients.
Absolutely. So this is just to kind of highlight a kind of wordy slide, but for your reference, and just to highlight the fact that there are many ongoing and planned studies to look at other newer RET inhibitors. I think Dr. Subbiah and his team are understanding a lot about novel resistance mechanisms and what are the strategies to overcome those resistance mechanisms with the next generation of RET inhibitors. So I think an exciting time for the RET patients.
Again, this slide shows RET pathway resistance mechanisms. Again, what we are learning more and more is, as with any of our tyrosine kinase inhibitors, although we are thrilled by the success, again, after 2, 3, 4 years, these tumors do develop resistance. So what are the resistance mechanisms that we see with selective RET inhibitors? One is the on-target resistance, and the other one is the off-target resistance. So what are the on-target resistance mechanisms? So both the selective RET inhibitors, selpercatinib and pralsetinib, cover this resistant mutation called gatekeeper mutation, the V804M, that are resistant to the multikinase inhibitors like vandatinib, cabozantinib, lenvatinib, sorafenib, sunitinib, so on and so forth. So pralsetinib and selpercatinib have that advantage. But unfortunately, as a resistance mechanism, non-gatekeeper resistance mutation pops up. So what are the non-gatekeeper resistance mutations? So one is we call it the solvent front mutation, which is the G810, G8S, and G810R mutations, which is a C-lobe solvent front mutation. Another one is called the roof mutation, and another one is called the hinge mutation. So these are the on-target resistance mechanisms that we see to selective RET inhibitors. And the second generation RET inhibitors are being developed like LOXO260, HMO6, and among others, to overcome these on-target selective RET resistance mechanisms. So what is the other resistance mechanism, off-target? So off-target is primarily mediated by RAS-RAF pathway activation. One thing we've seen in non-small cell lung cancer is MET amplification as one of the mechanisms of resistance. In fact, there have been anecdotal cases reported of selpercatinib being combined with crizotinib to overcome and circumvent the mechanism of resistance. So these are interesting. So more and more patients with colorectal pancreatic cancer are going to be treated in the community. We will be seeing additional mechanisms of resistance. I've seen a patient with NTRK3 fusion as a mechanism of resistance in a patient with KIF5B RET fusion, positive cancer. Again, the question is, can we treat these two fusion patients with laratracin and selpercatinib? Again, time will tell. We've done the preclinical work, and hopefully, if there is a next patient who develops a resistance mechanism, we have the preclinical proof of concept data in. And beyond these two on-target and off-target selective resistance mechanisms, another mechanism, unique mechanism called histological transformation to either from non-small cell lung cancer to squamous lung cancer or small cell lung cancer has also been reported to selective RET inhibitors. Again, these on-target, off-target, and histological transformation resistant mechanism are becoming a common theme to highly potent kinase inhibitors. So again, recent updates on TRK inhibitor therapy. I'll hand it over to Dr. Beg.
All right. So let's change gears and talk about a patient with metastatic pancreas cancer. So Richard's a 63-year-old gentleman who presents with weight loss, vomiting, pain, and jaundice, and has elevated LFTs, elevated tumor markers, and is found to have a mass in the pancreas obstructing the bile duct. So how would we approach baseline testing for this patient, and how would we incorporate genomic sequencing for this group of patients and test for alterations such as RET and NTRK? I'll throw this question to you, Dr. Parikh, in terms of approaching pancreas cancer patients in terms of diagnosis, tissue acquisition, and genomic testing.
Yeah, so pancreatic cancer is a little bit tougher even in terms of sometimes the tissue acquisition, especially if you just have the primary and not a lot of liver metastases if it's a locally advanced tumor, just in terms of the quality of specimen you can get. And we have worked over the years with our interventional colleagues just to ensure that they're no longer just getting FNAs and getting good blocks for molecular testing. Unlike colon cancer, where the pie is certainly divided up in many pieces, the pie is still quite intact in pancreatic cancer. The MSI high pancreatic cancer patients are also exceedingly low, 1 to 2% at best. I think even 2% is generous for MET PDAC. Again, we're making some headway with KRAS, which is 80% of pancreatic cancers. So, yes, we are still searching and kind of looking for that needle in the haystack because we don't yet have the armamentarium that we have in colon cancer for pancreatic cancer, and our chemotherapies are still limited. We have FOLFIRINOX and maybe NALIRI kind of comes into play with the data here at GISCO and Gem/Abraxane, but beyond that you have to look because the median OS for these patients is 12 to 14 months. So same testing applies, looking for comprehensive genomic profiling, but again, RNA is still important here to try to find some of these. So absolutely should be testing for RET and TRK here too.
Thank you. Dr. Rashid?
So the NTRK genes, they code for TRK. These are 3 different proteins on 3 different chromosomes. Normally, they are active in neural tissue, and you can see the function. They are not sort of oncogenes or tumor suppressor genes by themselves. And again, they can have a fusion with multiple different partners which differ from tumor type to tumor type. And you have in-frame rearrangement where the sort of NTRK fuses with a 5' partner. And so again, I think we are talking about pancreatic and colon cancer. That's the reason these are highlighted. They are in these tumors also, but they can be present in a variety of other tumors, normally less than 1%. Some of the tumors, they are high, which are very rare tumor, like memory analog of secretory carcinoma and secretory breast cancer. So this is salivary gland breast cancer. This is adult patient. In children, infantile fibrosarcoma and congenital nephroma, again rare. So it can be present in it's more frequent in these 4 tumors, but other normal, sort of other more common tumors, it's a rare event. And this is a slide which shows that European Society of Medical Oncology working group recommendations that you should test for RET rearrangement using broad panel assays, and in tumors where it is highly recurrent, like thyroid and lung, for instance, you can use FISH or RT-PCR based assay. And similarly in NTRK fusion, again, sort of you want to do it in advanced tumor without actionable driver, or tumors that are more likely to harbor NTRK gene fusions. And they can be tested before or during the standard treatment, or a patient with an advanced solid tumor, and different methods that can be used. And again, we have gone over sort of these methods in detail. So both of these have to be tested, mostly in the tumors that you guys deal with. It's going to be less than 1%, so it probably is going to be better to have a broad-based, NGS-based method.
Great. So let's move on with Richard. He has genomic testing performed, and we captured NTRK fusion. I think we got enough tissue, we ordered the right test, we found the RET fusion, the NTRK fusion, and now we have options for systemic therapy for this patient. And I guess the first question here is whether we would start with chemotherapy or reserve TRK inhibitor for later. So I'm going to poll my colleagues and ask them how they would approach for this disease with this alteration.
Yeah, I think still first line is still chemotherapy is still your kind of standard of care choice. I think we're seeing across targeted therapies more and more movement to move some of these targets into the first line setting. But even in BRAF V600E colorectal cancer, the first line strategy is still in combination with chemo. In HER2, the HER2 just got an FDA label today, and with Herceptin and tucatinib, and their first line trial is with chemotherapy. So in a pancreatic cancer patient where that could progress quite rapidly, and you might lose your window of opportunity to treat if you don't get a response, it might be tempting to give a TRK inhibitor in the first line, but I would still stick with standard chemotherapy first, and then kind of reserve, Laratracin or entrectinib for a second line. I don't know if you agree or disagree.
So, since this looks like a presidential debate, probably we should debate on just one topic. And I agree to disagree here. So again, in this patient with advanced pancreatic cancer, again, if this, I would probably prioritize an NTRK inhibitor if we find the NTRK fusion at diagnosis, because extrapolating from all the NTRK and RET positive cancers, we can create a decisive assault with these targeted, highly potent kinase inhibitors right from the get-go. Something happens to, cancer in the second line setting, the response rate is uptended and diminished. So again, if there are two schools of thought. If a GI oncologist can discuss about chemotherapy, and a targeted therapy oncologist can definitely discuss about starting targeted therapy at the frontline setting. Again, let's ask Dr. Begg what he would do.
I will present the data to our audience and let them decide for themselves. So let's take a deeper dive. And again, to both points, we know that for pancreatic cancer, according to some cohorts, up to 50% of patients may not be well enough to tolerate second-line therapy. So that's one strategy, that one aspect of the complication around this disease that is very unique to pancreatic cancer. We don't see that in colorectal cancer and other diseases. So let's take a deep dive into what these medications have, and then we'll see what our audience thinks. So we have two FDA approved treatments for TRK fusions. We have Laratracin and entrectinib. Their FDA approvals are very similar. Laratracin is approved for adults and peds, patients with solid tumors that have NTRK fusions without a known acquired mutation and have no satisfactory alternative treatments or have progressed following treatment. And very similar language around entrectinib as well, which is also saying who are metastatic, not an option for surgery, and have progressed on one line or do not have satisfactory alternative therapy. And here you're seeing a GI oncologist considering chemo as adequate treatment for pancreas cancer, and targeted oncologist saying no, that is not the scenario. And I think that we are allowed to have that kind of discussion with the patient when we talk to them about the different treatment options that we have. And we also have treatment options that are being developed right now for refractory disease with repotrectinib and selatrectinib. So a little bit of a deep dive into laratractinib. This is the first selective pan-TRK inhibitor in development. It's a highly potent molecule with prolonged responses seen in patients who have TRK fusions. The recommended dose based on phase 2 studies is 100 milligrams twice a day. I always get a little cautious when folks say that there's promising tolerability, because it's our patients who are taking these medications and it's for them to decide. But let's take a deep dive into what the side effect profiles are around these medications in a moment. Dr. Rashid talked about the distribution of TRK fusions across multiple tumor types, and he saw that there's a smattering of TRK fusions across all specific tumor types. When we look at the trials that enrolled patients for treatment with laratracin, most of the patients had soft tissue sarcomas or fibrosarcomas. There's a smattering of thyroid, salivary gland, lung, colon, and then you have really those small slices of the pie, which includes a lot of our GI cancer, melanoma, GIST, some unknown primary, and prostate cancer. But what we're seeing is that the overall response rate in this group of patients approaches 69%. We're seeing 21% complete response rate, 43% partial response rate, and only 8% progressive disease with this regimen for this group of patients. At what cost? Well, what does that translate into survival? These are not the regular randomized controlled trial arms that we're used to seeing for cases and controls. Speaks to the field that we are in right now in terms of the development of molecularly targeted therapy. But if we look at the graph on the right-hand side, it shows fairly compelling overall survival data with a 4-year survival of 64%. If we look at 60 months, that's 5-year survival. It's more than 50% for this group of patients being treated with TRK-directed therapy. So what is the cost of treatment? Cost to our patients are the adverse events that our treatments can provide them. I want you to focus on the right-hand side of this graph, which highlights the AEs related to Laratracin. The most common side effects are AST, ALT elevation, cough, and fatigue and dizziness. Most of these side effects are mild, quote unquote. These are grade 1 or grade 2 events, and these can be managed conservatively in some situations with dose adjustments. The grade 3 side effects that we see with this medications include some AST, ALT elevations, but also increased weight, neutrophil, neutropenia, and these are factors that we need to think about. And before this meeting, our presentation, we were talking about the weight gain effect for TRK inhibitors, and it looks like this is a peculiar on-target side effect that we see for this group of patients. And would the panel like to comment on quality of life impact for this side effect?
Again, this is a non-target toxicity that we see. Again, in cancer patients, if they gain weight, I'm happy many times. And if it's an adolescent young adult, if they can do exercise, we can also talk. If they are doing so well, and if they want to think about weight control measures, then we talk about sibutramine, orlistat, and discuss with an endocrinologist as well. But in patients with cancer, especially in the relapsed refractory setting, if they start gaining weight, a majority part of me is happy.
Let's continue with some clinical follow-up for Laratracin. Again, 78% lower risk of death with Laratracin, median survival in their cohorts approaching 40 months for patients on this treatment. On the right-hand side, you'll see the comparison of the Laratracin cohort with a real-world data cohort receiving standard of care therapy in the red curves, and we can see how there's clear separation of the curves with markedly improved survival on patients receiving targeted therapy with Laratracin versus standard of care, which in this group of patients would largely have been some version of chemotherapy. There was weighting analysis done because a lot of these trials had diseases with multiple tumor types with varying baseline characteristics. So there has been pretty heavy statistical adjustments to adjust for these characteristics and make sure we're not biased for low-grade tumors being also positive for TRK fusions, leading to prognostic benefits and not truly a drug effect. But here you'll see on these curves that this is truly looking like a drug effect for this disease. Changing gears to entrectinib. Entrectinib is a pan inhibitor of TRK, ROS1, and ALK. And what's important about this, about these different pathways, is that they do cause redundancies that lead to proliferation, improved cancer survival, and providing a pan inhibitor does improve the ability to prevent compensatory pathways and improve the efficacy of our targeted therapy. And we're also in a world where we're thinking about combining different medications with unique targeting approaches for this group of patients. And let's see how this panned out in the clinical world. This slide summarizes the updated efficacy results with entrectinib across multiple tumor types. I want you to focus on the table, with the first row being overall overall response rate. We're seeing the overall response rate in the entire population was 61%. here, which was fairly preserved whether or not the patients had CNS metastases. Again, 16% complete response rate, 44% partial response rate, with a median progression-free survival of 13.8 months and median overall survival approaching 40 months. So very compelling data here in terms of efficacy with entrectinib for patients with TRK fusions. At what cost? What are the side effects that patients can experience with these medications? We're seeing pretty similar side effect profiles in what we were seeing earlier. We're seeing some taste changes and elevated LFTs, and most of these do appear to be grade 1, grade 2. If we focus on the grade 3 toxicities, we're seeing fatigue, weight gain, and anemia, and then some odd dizziness, diarrhea, and peripheral edema. Again, emphasizing that we need to go back to our clinical roots, continue to make sure we monitor our patients carefully, and most of these side effects improved with dose adjustments, and only 4% of patients needed to discontinue their treatment due to treatment-related adverse events. A word on what's coming down the pike in terms of next-generation inhibitors for TRK. We have repotrectinib and selatrectinib. Repo is designed to bind within the ATP binding boundary and can target wild-type and mutated kinases. There's a phase 1/2 trial evaluating Repo for patients who have ALK-ROS1 and NTRK fusion genes, so we'll look forward to hearing more data in that space. Selatrectinib is believed to bind to the TRK kinase domain and reestablishes the blockage of downstream signaling pathways, again, removing compensatory pathways, which may lead to secondary or primary, for that matter, paths of resistance to TRK pathway blockage. This slide is here to show patients who did have acquired resistance mutations to TRK inhibitors who were treated with selatrectinib, deriving fairly impressive clinical response. Here we're seeing fairly marked shrinkage of the disease in the patient. And these are the first 2 patients treated with selatrectinib. So exciting field, and again, how we're seeing the EGFR space, the ALK space in the lung cancer, the FGFR space for cholangiocarcinoma. We're seeing sequencing of treatments developing for TRK fusion, which is wonderful for our patients.
Back to Richard's case.
Yeah, so I guess very similar discussions to what we're having before. Like, what is a good response? If and if someone is suffering from adverse events on these medications, what do we do with their doses? When is enough treatment sufficient? And I'm still grappling with the decision on how to treat people who have a clinical complete response. Curious to what your thoughts are for this group of patients.
Yeah, I mean, again, these are rare, so I've only kind of had a handful of both TRK and RET, and kind of will defer to Dr. Subbiah about clinical complete responses. Haven't had yet kind of a patient that's had a complete clinical response, so have just treated to progression, but I'm not sure. Have you seen any?
And again, because these patients have a higher disease burden, I think they still have some clones probably going on. So unless if this is a part of a neoadjuvant strategy, wherein we get to a tumor reduction where we can take the tumor out and stop treatment, we don't have the answers yet. I think it should be guided by the clinical status of that patient. We need to really have a reasonable discussion with the patient. I think here we can take cues from imatinib, from CML, and imatinib from GIST. It's good that we are talking about imatinib and long-term therapy in these patients. It's great to talk about that. And have these debates whether to stop treatment, continue treatment, for things like that. I think this is, exciting times to be in oncology.
And I guess that the take home is to make the decisions on continuing treatment based on patient tolerability rather than duration or depth of response, because you could have someone with a partial response who is deriving tremendous clinical benefit. The clinical response complete clinical response isn't necessarily a goal to achieve in a lot of these patients.
So to just conclude in the next 5 minutes, then we'll take some questions from here. So again, this ties in for the whole discussion. So this was a pancreatic metastatic ductal adenocarcinoma of Dr. Schallenberg. Patient was treated by FOLFIRINOX and FOLFIRI for 6 months and unfortunately had to discontinue due to PD. This adolescent young adult patient, Dr. Begg, sent for molecular profiling and found a red fusion. Patient was MSS stable and KRAS and BRAF were wild type. So I still remember the text Dr. Begg sent me.
I did not text him. I sent him a direct message on Twitter because he was tweeting about a new trial that he had just opened. This is like 5 or 6 years ago.
So that is the power of Twitter here, right? So he DM'd me on Twitter, and I'm like, yeah, I saw the patient the next day, and I saw the patient the next day, enrolled the patient on the selpercatinib study, and fantastic response rates. And the patient is still on therapy. You can see the responses and deepening of responses, over 50% reduction of target lesions, manageable low-grade AEs, and it's rewarding to treat such patients. The response is ongoing at now I can update at 50 months now. And again, these patients, these such patients as a group, extremely rare patients, these needles in haystacks of patients here, again led to tissue agnostic approval of selpercatinib in red fusion positive cancers. Again, this is the latest tissue agnostic approval, September 21, 2022, as the latest tissue agnostic approval. It's approved in all patients, regardless of fusion partner, and it's active regardless of prior lines of therapy, regardless of tumor type. Great.
And Vivek,
So-
I want to make one point
Yeah.
on this graph, and a lot of the stuff that we're talking about today is predicated on oncologists ordering the test. That patient, I was not universally testing my pancreas patients. This is before MSI data, even when we tested her. And I look at this graph every time you show it, and she's the rightmost graph on change from baseline. And I can't help but think about situations where I may have forgotten or not tested specific patients, and how many patients we may have not been able to offer these treatments. So I think remembering to test, before we start our treatment, talking to our pathologists is just so important.
Yeah. So don't guess, do NGS. That's your message. Right? So, all right. So we are running out of time. We have just 5 minutes for Q&A. Let's take some questions from the audience. I have some questions here. The first question is efficacy tied to tumor volume? So who wants to take the question? Who wants to take it? If efficacy tied to tumor volume?
Yeah, I mean, no, but I think we do know that overall, patients do better when their disease burden is lower. And I mean, my God, looking at that CAT scan in 50 months is incredible. So I'm so intrigued if you were to biopsy those liver lesions that there was anything.
Absolutely. I think efficacy is tied, not more than tumor volume. Of course, tumor volume, if they have a low burden, they have a better response. But efficacy is tied to prior lines of therapy. Efficacy is also tied to the co-occurring alterations in that patient. And efficacy is also tied to the dose that they can tolerate. If they can tolerate the maximum approved dose for quite a long time, and efficacy is tied to that. So the next question is, should all new patient tumors with colon cancer undergo DNA-based NGS?
And RNA.
And RNA-based NGS, right? Yes. So that's the answer. So next question. Okay, this is a question, I don't know how to answer this question. None of us know, except Dr. Rashid here. How often do you macro dissect to improve sensitivity?
So the idea is that the biopsy or the resection specimen, we mark the area of the tumor. If it's less than 20% tumor in that marked area, we can't do that. That's our threshold. It has to be 5% of tumor allele there for us to find it. So the pathologists call everything 20%. So that they want us to sequence their tumor or the one that they have marked. So majority of the things that we have, we are able to do it. Older samples don't work. If it's 5-10 years old sample, does not work well. some samples, for some odd reasons, about 50% of our volume is, these are patients who had biopsy or resection somewhere else. So these are outside material. Some of that may not work also. For some odd reason, some samples don't work. But a majority of samples, we are able to generate a report.
So again, the next question is risks and side effects long term. I think we discussed that. The next question is, please discuss routine germline genetic testing for patients with pancreatic ductal adenocarcinoma. Dr. Beck, do you want to take that?
Yeah. So both germline testing for pancreatic cancer and somatic testing for pancreatic cancer is recommended through NCCN. In talking to different companies and different vendors, my take home is that the normal somatic testing that we do, that we've talked all of our presentation today about, is not well adjusted for germline mutations, that we should order them separately. And that could be a lot of testing for our patients up front, but they do lead to very different algorithms in terms of screening, early detection, use of PARP inhibitors, and other aspects. But I wonder, Dr. Rashid, if there is any technical advancement that's coming up which will make this redundant.
So occasionally we find germline mutations. We don't report it on the, we email the genetic counselor and the physician, because our assays are not validated. Most labs, these are not validated for germline testing. We don't comprehensively test all the germline mutations. So that's the reason that we don't report it. But I've seen sort of reports, I think they send it out for pancreatic cancer, of course, for colon cancer also. Some of that we do in-house, but some of that is sent out also.
Thank you. And any relationship between age and any genetic testing? Age?
No, so in pancreatic cancer, as Dr. Begg mentioned, it's all patients with pancreatic cancer, and there's a movement to same with colorectal cancer, just to do germline testing on all patients. Yeah, and I guess that was referring to germline, but same thing with somatic, no age dependency.
Thank you. Maybe one more question, and we will wrap it up. So do you prefer and can obtain fresh biopsy rather than rely on archival tissue testing, or do you see change over time of targeted biomarker and genetic alterations?
Yeah, so I mean, I think it's a good question about when do you re-biopsy, so you treat at the time, initially. I think that's one of the promises of, I think, liquid biopsies is to, do the serial testing at the time of resistance, to understand, acquired resistance mechanisms, and, try to think about your next line of therapy. So it depends, from the initial, diagnosis to now. But generally speaking, if it's a, new metastatic diagnosis, even from a prior, adjuvant setting, we'll do a new biopsy for that patient.
All right, that's a wrap. So with that, we conclude our session for today. I thank the organizers and the amazing speakers. I think this was a terrific debate. We can go on and on. So until next year, thank you so much.
Thank you. Thanks for your attention.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/PCK860. This activity is supported by an educational grant from Lilly.